start from the beginning here. Okay, colleagues, we're having Dr. Kekana. We're using a different approach now. Please go ahead, Dr. Kekana. They can hear you.
Okay. Sorry about that. Colorectal cancer is the second leading cause of cancer-related death in the world, accounting for approximately 550,000 deaths per year globally. About 25 to 50% of colorectal cancer patients present at the early stage, and the remaining 25 are diagnosed at advanced stage, which then translate into poor prognosis. We have a 5-year survival rate of 14%, which is terribly low. Most are slow growing and arising from pre-cancer lesions such as adenomatous polyposis and also the serrated sessile polyps. They're slow growing, which enables us, it actually gives us a window to be able to stop the progression from adenoma to carcinoma as the usual sequence. But now you see that even in developed countries, the screening remains badly used at about 19 to 69% at the highest. So now looking at the types of cancers we have, like I said, we have about 85, the highest is being sporadic. So most of the cancers that are going to be presenting to us are sporadic. Sporadic meaning there is no family history, there is no familial inheritance. It's just happening due to age. And then the remaining about 15% would then be hereditary and familial. But remember today, what we're talking about, we are talking about patients that do not have symptoms. So patients do not have symptoms. We are now saying, who are we enrolling on the screening programs? And what is the data saying about the screening programs that we have? So this is adenoma to carcinoma sequence that we have from the adenoma normal colon and then the mutations up until we have a carcinoma. So then you see that the proliferation from normal mucosa to proliferation of the epithelium to adenoma, there is some inactivation that happens and methylation that happens to the cells. Then later when you have adenoma, you are not then going to also be having a cancer soon. But this takes years. It actually takes years from adenoma to carcinoma. So the goal of screening is to find patients while they're at a pre-malignant condition and therefore prevent mortality, morbidity associated with colorectal cancer. So what are the risk factors? Indeed, age, which is what we are going to focus more on today when I give you the stats and the protocol and updated screening protocol, but also patients with inflammatory bowel disease are at the risk factor. The patients with sedentary lifestyle, people who are not active, who are what they call couch potatoes in this latest modern language, obesity, poor dietary habit, smoking and alcohol consumptions, and comorbidities. There is a group that actually looked at diabetes just to preview, and they realized that when you are diabetic, the chances of colorectal malignancy are equated to somebody who has the same as somebody who has a high risk of a family member having a colorectal carcinoma. Somebody with the diabetes, you cannot put them on the average risk for colorectal malignancy. So this table is just to to demonstrate for you that when you are male, you have high risk. When you are older, you have high risk. So most of the cancers that were diagnosed, just to deal with age, are between 65 and more. Those are most of the cancers. But they realize that 10% of the cancers are diagnosed at the age less than 50. And therefore, when your screening is at 50, which is what initially was given, you actually have problems. You are going to miss the younger patients who are going to present earlier with colorectal malignancy. By the time you screen them at 50, you are going to have a problem. So therefore, when you are male and you are older age, the risk factor family history with I alluded to that. There is diabetes creeping up as well. And then we know that the lifestyle, things that we can really control in terms of lifestyle is alcohol consumption, obesity, physical activity, and smoking. But also look at the diet. Consumption of red meat and processed meat increases your risk factor. Fruits and vegetables lowers it. Fiber, whole grain, fish, dairy products lowers the risks. So now let's look at the summation of racial differences with colorectal cancer. Just show you the Black American. This was taken from Black American compared to white, with allude to the colorectal malignancy. So Black people have increased number of adenomas more than 9 millimeters, and increased proximal number of adenomas. So the cancers are not only on the left, majority of them. For the Blacks are also on the right, which is why later, when we choose the best screening modality, we need to be able to realize the shortcomings of the sigmoidoscopy in contrast to the full colonoscopy. The onset is early and is sporadic, and increased proximal colorectal cancer, increased the bacteria in the colon as well, and then increased pro-inflammatory and enterobacter species in the colon. But then also when you look at the genetic differences, you have a decreased frequency of MSIH for colorectal, where survival is better, and increased frequency of inflammatory associated microsatellite alterations, and that will then also translate into poor survival. And then you have a KRAS, the infamous KRAS mutation that also leads to the mutation, and also leads to colorectal cancer. So then screening and surveillance difference for Black American is that to lower the frequency of the population of colorectal screening uptake, to lower the frequency of colonoscope screening uptake, and to lower the frequency of the follow-up was the risk. Just to go back to the diet. So this is what they did with this table. These professors looked at the diet specifically, and they said, for 2 weeks, let's exchange the diet. So let African Americans, let's feed them higher fiber and a low-fat African style diet. And then the rural Africans, they fed them a high-fat diet and a low-fiber Western style kind of a diet. And then in 2 weeks, when they rescoped, so initially they scoped them and they took the mucosa of the colon. And then after 2 weeks, just for 2 weeks after swapping the diet, when they took the mucosa of them, they realized that the ones that had a high fiber, the proliferation was halved in 50%. Proliferation from adenoma to carcinoma was halved, was actually decreased by 50%. But the other ones, proliferation was actually increased, which then translated that the diet actually does more quicker job than you can think. So when somebody eats a high fiber diet, they are more protected compared to somebody who is eating a low fiber diet. In the olden days, we were told that cancer is a rich man's disease. But then you will then realize that once we started moving into town, we started having the cancers that were mostly seen in white people, and they were not seen much in Blacks. But now when the Blacks started assuming the same diet of white people, then they started developing the same colorectal cancer at the same speed. So now this is what the diet. So diet is quite important. Now let's talk about screening. So the questions is who, when, and how. So what I can tell you is that the best screening tool is the one which is carried out. So we can talk and have meetings and talk about the screenings, but if you don't carry them out, they translate into nothing. So this is the knowledge that you incur and the knowledge that you need to practice going further. So the screening is directed by data. So what happened is the American Society, the College of Gastroenterology, looked at the data, and they said that screening prior, they had said that screening starts from 50 going up. And they realized within that age, 50 and upwards, the mortality was actually lowered because of the screening. And because they were able to pick up the adenomas and then follow up the patients and stratify them as risks. And then they also realized that the mortality in terms of caused by colorectal cancer in a younger group was actually going up. And they realized that they need to now lower. The decision was made by the task force to that we are going to lower the screening to 45. As we are sitting now, the screening for colorectal cancer is at 45 years of age, because they realize in actually Black Americans, the onset is quite early. So then average person who has average risk, this is a person, average risk is the person who has no risk of family history of colorectal cancer, who has no genetic inheritance of colorectal cancer. It's just a person with average risks. The screening starts at 45. So then we then also realize that the screening benefits, it outweighs the treat. So the cost of treating is much more exorbitant to the system. It's also much more labor intensive compared to the screening. Also screening, it depends on the workforce you have, but it's better to have the workforce to prevent than the workforce to treat, because then the workforce to treat would include your ICU, will include your everything until the oncologies. But for screening, it just includes the team that does the gastroenterology, the surgeons, and then people who are just trained to do scopes. So now the stratification is on average risk, which is what we've just dealt with. And then increased risks is people that has a family history of colorectal malignancy. And then high risk is familial. So all those APC genes, the hereditary non-polyposis, which is called the Lynch syndrome, those are high risks. But now let's look at the modalities we have. So as we sit now, the gold standard of screening is colonoscopy. But there are other modalities that comes up or, steps up to the level of colonoscopy, but not really, they're not the gold standard. So let's start with a stool-based GWAC test, this one. So the stool-based GWAC test is an annual test that patients can give you stools, and then you check for the presence of blood. The lab will check, and then they will then say if it's positive or not. But the high sensitive GWAC-based test, you need 3 stools to be able to draw a better conclusion. Another thing is that you need 3 stools. It's dietary restrictive. So there's certain diet that you shouldn't be on before you do the test. Otherwise, they will give you a false positive test. And then that test, you do it annually. But there is a fit test which is much more better than the GWAC test. That one also, you just need 1 stool. It's not dietary inhibiting, or you don't need to modify your diet before the test. But what is now, which is done annually, but the DNA testing includes it's a combination of fecal occult blood test and the DNA testing. So all and above testing for the presence of blood, the test goes ahead to test for the DNA in the same blood that you picked up, which gives you a good pickup rate. If you check the pickup in advance in colon cancer is 93%, but it's actually slightly bad in advanced adenoma, because then you can have early and a late adenoma. So in advanced adenoma is quite bad, but the pickup rate is quite good. And then the other test that you look at, and this is done every 3 years. So once you do it, you don't have to do it annually. And this annual test, the fecal occult blood test, and the DNA and the fit test, stool fit test, is labor intensive. If you can check the compliance of this thing tends to be low, because it has to be done every year. Patient might not be willing to be mailing their feces every year to the lab so that they can test. So therefore, this DNA test, it's a combination of fecal occult blood and the DNA testing. Is much more better. You do it once in 3 years, and then there's a flexible. There is colonography, which is an imaging. So CT colonography has a good pickup. If you check, is 86 to 100%. Sensitivity, specificity goes down. It depends on the size of the adenoma itself, but it's still quite a good test. So these tests that I just mentioned to you now, the FIT test, the DNA test, and the CT colonography, those is what we call a two-step screening test, meaning if any of these tests are positive, you still need to take the patient for colonoscopy and then and render the intervention. So these tests that I just said to you are it's a test. It's not therapeutic. It's testing. It doesn't have a therapeutic a benefit. Flexible endoscopy, flexible sigmoidoscopy. It's best if you check the pickup. It's about 58 to 75%. And the specificity to pick up adenoma is high. But the catch about this is that you don't interrogate the whole colon. But if you take flexible sigmoidoscopy and combine it with a FIT test, a fecal test, but the FIT test, not the QUAC test, it gives you almost same sensitivity as the colonoscopy. So you can get away in a setting where you only have a sigmoidoscopy. To do sigmoidoscopy every 5 years, but then yearly you do your FIT test. It gives you the same pickup rate as the colonoscopy. But the colonoscopies are gold standard with a pickup of 94.7, and then also the good pickup of adenoma, whether early or also even late, and also even when the size is quite small. Specificity and sensitivity is quite high. So the gold standard today, as we sit, is colonoscopy. So if you have a patient who is 45 years old, the patient does not need to give you symptoms for you to send them for screening program. When they're 45, especially when the black males, you should be trigger happy to be sending them for colonoscopy. If they give you a sign, you are already late, because now we're talking about people who are asymptomatic, the ones that we can easily dismiss in our rooms to say, but we don't think there's much. So those are the tests. And there's another test, the blood test, which I didn't include here, the Septin 9 test that you can actually take blood and test. I'm not sure if they're offering it in South Africa at the moment. But there's also a septin test that one can actually take blood and it gives them results. So I've already dealt with the modality 1-step versus 2-step. 1-step means you are interrogating, you're investigating. It also gives you the benefit of intervention. But 2-step is that when that test is positive, the patient still needs to go for a colonoscopy. Just to go back, CT colonography, it's the patient goes into a CT scan. That's why it's a CT. So the same thing happens. But now the catch about CT colonography is that you send the patient there, you need to bowel prep them. So the same things that you do with a colonoscopy is the same thing that you do when you order CT colonography. So you might as well send the patient to be scoped, because they need a bowel prep. The same thing, they will have to put in a gas and then put in a contrast in the colon. The colon is to be properly cleaned. And then, but with the CT colonography, as labor intensive as it is, if there's anything that is suspicious needs to be biopsied, the patient will have to now still go again and bowel prep again, and then be done a colonoscopy, or be done in the same setting. So that's why CT colonography is part of a 2-step modality. Now, so sorry, this is what I said already. Colonoscopy remains the gold standard. It has a sensitivity and specificity is high. It allows you to identify the malignancy and a pre-malignant lesion as well. And then you have all these gadgets that you can use to tattoo, to snare, if you are suspecting that this is a high risk lesion. And then it also allows you, like I'm saying, the therapy to remove the lesion that you suspect and get a definitive diagnosis. So for every good thing, obviously there are drawbacks, and the drawback of colonoscopy is that it's invasive. It requires bowel preparation and often requires sedation, and it's operator dependent. So if I was giving this talk to surgeons only, we are going to talk about the index of adenoma pickup on the patient, because that also plays a role. A good instrument in wrong hands translates into a bad instrument. So therefore, it's operator dependent. So somebody who's doing the colonoscopy should have have done a couple of them, or the pickup rate should actually be higher. And also be satisfactory. And then the social stigma and a lower compliance rates than ideal. So people really don't comply because you can understand it's invasive and all those things. And again, also the cost plays a role. And then this is the two-step that we talked about on that graph. And I think I've already exhausted this slides about two-step testing. What I didn't include, it's a video capsular colonoscopy. So this is a capsule that the patients get to be bowel prepped, and they swallow the capsule. The capsule goes on into the GIT, into the colon. It takes pictures. And then once the capsule is passed rectally, it's going to be decoded and then interpreted. But there are now well advanced capsules that are available that gives you real time pictures, and also they're degradable, so you don't even have to worry that you are going to lose a capsule. A patient has to go to the toilet, they need to be able to look for the capsule before they flush, or now some would have to resort into using a different mode before they discard the feces. So capsule endoscopy is also one of those tests that you can use, but also the drawback about it is a two-step. Should you see anything suspicious, you need to go and put a colonoscopy. And the alternative to colonoscopy, like I was saying, the sensitivity is high. They're less invasive, less expensive, except the capsule. Capsule is quite expensive, more widely accepted, and highly effective in prevention, because the pickup, it's okay, but you still need to go to colonoscopy. I cannot emphasize this more. So if you want to add one shot, you have one chance to make a difference, one chance to deal with what patient presents with. Just colonoscopy would be your first prize. So these are screening modalities that the U.S. Multi-Society Task Force colorectal guidelines gave us for patients with the average risk. So average risk, they were saying 50, but now remember, you have to drop it to 45 for African American patients. So the African patients, you have to drop it to 45. And I hope with the stats that I gave you, and I've convinced you enough that whatever that we're practicing at 50, we should have lowered it, because when you capture and when you capture 45, you're adding about 2 billion to the system. In terms of the patients that you need to enroll into the screening program, that is not the problem. All one needs to have, it's the manpower to do that. So it's not a problem. So it then says again that the average risk, you offer them colonoscopy once every 5 to 10 years. Flexible endoscopy, we said 3 to 5 years. And then you can offer them double contrast barium, which people don't prefer it, no more. That's why I didn't mention it then. But this also outlines the colon. If there's anything, you have to also do a colonoscopy. But with the barium, you won't be able to do colonoscopy right immediately. The patient would have to go home and come back some other time when the contrast is washed off the mucosa, so that you can be able to see properly. And fecal occult blood test that has to be done annually, and fecal immunochemistry test, which is a FIT test, also annually for the average risks. So for an increased risk patients, the risk factors of an increased risk is a colorectal cancer or adenomatous polyp in a first degree relative who's less than 60 years. So if in the family somebody has cancer less than 60, you are no longer now an average risk, you become a high risk. That's why the history taking with this patient is quite important. And then if they had colorectal cancer or adenomatous polyp in 2 or more first degree relative at any age, So if in the later age you have 3, you have 2 or 3. So the risk changes now to becoming a high risk in terms of that. And then the recommendation is that you have a screening beginning at the age of 40 or 10 years prior to the age of the youngest affected immediate family member. So then every 5 years thereof. So once you're in increased risk, the whole 45 changes completely. You are now dropped to 40. Or whichever one comes first between 40 or 10 years prior to the onset on the youngest patient. So if, for example, one of the family members had a colorectal cancer at 45 years, the other one had it at 60, the other one had it at 70. The youngest one would be our index case. And then we screen 10 years prior to that age, which will be 35. So now you can easily drop that age to 35 or lower than that, depending on the index case, which is the youngest patient. And now you do it 10 years prior, because it gives you a chance to repeat it again and again and actually monitor the patient. Because by the time somebody got the colorectal malignancy at 40, the adenoma to carcinoma sequence might have kicked in 10 years prior. So that's why the patient that you're going to put on a screening or surveillance, it's going to be the patient that is 10 years prior to the onset of the one that had. I hope it's clear. So therefore, the patient who had FAP, these are the patients that they inherited this, the Lynch syndrome, FAP, the patients with inflammatory bowel disease, Crohn's disease, and ulcerative colitis, because we know those that are familial. If somebody in a family had a syndrome that would give you soft tissue masses or soft tissue carcinoma or what we call a sarcomas, and they also have inflammatory disease. There's that syndrome. So even somebody who had the sarcoma, you must be able to ask them and interrogate them promptly about the GIT symptoms. Then you will pick up that syndrome, say that now this is familial as well. So they will then fall into this high risks. So what do we do for those? What are the recommendations for those patients with the high risk? Is that your screening begins at the age between 10 and 12 with an annual flexible sigmoidoscopy. So you can see that somebody with hereditary, you will have to screen children. That's why it's very important that even when kids come with parectal bleeding, you don't just dismiss it. And then those need genetic counseling, testing. And then some of these patients would need, the FAP would need the prophylactic colectomy. The patients with FAP, there is 100% that they will get colorectal malignancy. So there's no two-way about it. Those are patients that it's advocated that they get followed up by the surgeons or gastroenterologists, and when they get to 18 or so, once they finish school, we offer them elective colectomy, and then so that we eliminate completely the risk of them developing cancer. So we usually offer them after when they're when they're in early adulthood. It's easier to manage such a person and make them understand what they also facing. And the screening of colonoscopy begins at the age 20 to 25 for those with the Lynch syndrome. The Lynch syndrome is non-hereditary polyposis coli. So those patients are screened between 20 and 25, and then you screen them every year. So it becomes a yearly thing. In contrast to an average risk, which you screen every 10 years, higher risk 5 to 10 years. And then also you do genetic testing and counseling. And then you also have to get the other family members to be involved in the testing so that you can be able to prevent. And the ones with the inflammatory bowel disease, These are patients that need to be managed in a tertiary institution or managed by somebody who has an interest in this, so that they can be able to follow them up, because screening also starts at 8 years after the onset of the pancolitis, and then or prior to 12 to 15 years after the onset of left-sided colitis, with colonoscopy and biopsy to assess the dysplasia, because you realize this is an active thing that you have to do all the time. So again, risk stratification, when you look at the adenomas that you find, it's not, you have to also look at the histological profiling of them. You have to look at the number, you have to look at the size of them. So if they are 1 to 2, which is 1 centimeter tubuloadenomas, these ones are low grade. So if you check at the histology subtype, you realize that the villus are the ones that has the high risk of malignancy, turning into malignancy at 40%, which is quite considerable. So, but then those that are few of them, less than 1 centimeter, one can still do polypectomy, and they follow up as of an average risk patients. But the ones that are more than 3, you then drop the interval of colonoscopy to 3 years after a complete, and the word complete being a punchline, polypectomy. It has to be completely removed. But now the ones that has a high-grade dysplasia with villus features more than 10 on a single examination, sessile, or the ones that were removed in pieces, you drop the colonoscopy interval to less than 3 years after complete polypectomy. And then the ones that usually when you take them out, the sessile, and then you take them in pieces, because you must remember sessile, they are more flat on the surface than be able to be than pedunculated, if I could say that. So therefore, you then follow them up quite much, often 2 to 6 months, to verify that you completely excised that. So this is now, for these we actually dealt with in terms of the increased risk of how we are going to deal with it. Now let's go to our discussion to wrap it up. Now that we know what we're going to do with an average risk, we know what we're going to do with increased risk, and we know what we're going to do with the high risks. Now let's have a discussion. So what is an ideal screening test? Because that's what people usually ask. It has to be non-invasive, but high sensitive, high specific, be safe and readily available, convenient and inexpensive. But also is that the best, not ideal, the best is the one that is designed and promptly followed. So we can talk about the ideal screening test and then walk away and not implement it. It doesn't translate to anything. But now we know that the goal, we've proven with data, and we have shown that the best one is colonoscopy, though the issue about it is that it's invasive. But it's highly sensitive, specific, it's safe, it's readily available, it's convenient. But when it comes to expenses, it depends where you're coming from. So in conclusion, the question is who, when, and how. So everyone from the age of 50 years should be considered, but also consider 45 in Africans. And then you are going to drop that age to 40 when there is a family history. You are going to drop that age much more further, 10 years prior to the onset of the colorectal malignancy in the family members of those that had hereditary a cause of malignancy. So for sporadic, we are now saying 45 is the new 50. So the when is that you must stratify your patients. Where are they falling into? Then we'll know whether are we doing 2 to 6 months? Are we doing less than 6 months? Are we doing in 3 years as a high risk patients that we did polypectomy and there were more than 3? Or if it's 1 to 2 polyps that were completely removed, we're going back to saying 5 to 10 years. So therefore, stratify your patients will then direct on how you're going to go on. And the how is that colonoscopy is still a gold standard in screening for colorectal malignancy. And I would like to thank you. That is my business card in case you want to get to be in contact with us to refer patients. Thank you so much. Reference will be on request. I'll give you references, but I'm happy to take questions.
Thank you very much, Dr. Kekana. We won the battle today for technological challenges that we had at the beginning.
Thank you so much.
Yeah, I know that we'll call you again next time. No, it's a free hustle. No technological problems. We see your screen, and we'll be able to talk freely. But it went very well, and I think thank you very much for
Thank you so much.
Yeah, for taking us through this amazing disease, so to speak, because it's amazing that you spoke that even in children that we need to screen, because like you indicate that once you find it's in the family history, you go down up to children 8 to 10 years old. It's quite amazing that we go that far. Before we take other questions, but how prevalent is it in children? Now that we also screen for them.
Yeah, in children, it's controlled. Remember the graph that I showed where the pie graph that I showed.
Yeah,
it's sitting at about 5 to 6% of patients would have hereditary cause of colorectal cancer. So we're sitting at that, and then the patients that has hereditary causes of colorectal cancer. Once you are in that family, this is the autosomal dominant gene that they are inheriting. So that is why once they picked up in that family, that's why they need genetic counseling, the whole family, that you now actively start identifying them before they identify themselves, because by the time they do that, it's already late. So the number is not that much. It's actually about 5 to 6%. Of the colon cancer, that the colorectal cancers you're going to see, they're going to be coming from the inheritance as well.
Yeah. So I think the purpose of the screening test is to pick it up before it happens. Because sometimes when by the time you diagnose it, it's too late to spread. Which is why the question by Dr. Nevonda then says about bone metastasis of colorectal cancer is very rare, and the mechanism of spread was not exactly known last I read. And has the status changed?
Say that again. I didn't pick that up.
The bone metastasis of colorectal cancer. Does it happen? Do you have bone metastasis? And he's asking if the status has changed. Is it still the case?
We rarely see the bone metastases in colorectal cancer, but it's not something that is not unheard of.
Yeah.
The catch is this: most of the cancers that we have, except the lower rectal to anal cancers, the drainage is by the inguinal lymph nodes and then to the whole system. But the other remaining, the middle part of the rectum upwards, the drainage is to the liver. So we see the liver mets first, then followed by the lung metastases, and then later on you can have bone metastases. But bone metastasis it's quite different compared to prostate cancer, if I can use that, which doesn't really have to go through the liver.
Okay.
It's the spread is through the hematological, and then it's through the whole system. That's why you easily see bone metastasis with prostate in contrast with colorectal. But the lower colorectal cancer are able to give you bone mets, but it's not something that you see quite often. I must still say it's rare. It's 1 or 2 cases that I saw in my short career.
Okay. I think one of the other matters that is quite scary is that, well, maybe not scary, but I just want to check. In terms of screening, self-screening, self-referral, and maybe GP practice, we encourage everyone. Now, take it, it's the prevalence, my assumption, or maybe correct me, is that it's more male than female. And also, if that is the case, if I'm correct. And also, how many of us, maybe if I could just do, if I could see the hands and say how many of the colleagues who are over 50, like me here, who have ever done screening tests. And, that's, I mean, it's colorectal coloscopy, it's not something that one could easily contemplate. Yeah, maybe your comments on that.
Unfortunately, like I've shown that table that I started with of the risk factors, is that it tends to be more in males than females.
Yeah.
So that's why I'm saying when you are a male and then you pull a trigger at 40 for prostate cancer, at 45 you need to pull a trigger to go and at least get your first colonoscopy at 45. Then you know that if nothing really is picked up, it's normal. You come back again when you are 50 or actually 55. So in that 10 years, it's actually much more better, because at that 45 we would have excluded anything brewing. And if anything starts brewing after that, when you're close to 50, it's less likely that we will miss it, because you're going to come back again when you're 55. So it's actually quite important to screen. Yes, it's leaning more towards males, and the very same males that don't like to be examined or don't like to consult are the very one that gets the hit first. By the time a male consults, you are now talking about somebody who can't even walk. By that time, they present with a low HP. By that time, you're already late. That means the cancer is already, whatever it is already bleeding, and it's most likely a cancer.
Yeah. There are some questions in the chat box, but there was a hand here. Some colleagues say, Nkosi, I see your hand was up, but it's down now. Do you want to ask a question? Some colleagues see Nkosi. Whilst you're still unmuting yourself, if Kamu can help. There's a question for Muhadin Khan here. Thanks for lift that no tech issues and important to align with those screening. But we have those investigative tests available in South Africa. I mean, there's a gamut of tests that you listed there. Do we have them readily available in our country?
So other tests, yeah, the tests that are here that I actually spoke about, we do actually have them in our country. So I dealt more with the ones that we actually do have in our country, so that it's easier for people to be referred there.
Okay.
So we do have the fecal occult test, and I mean some of the doctors that send patients to me, they've done some few. So those tests are actually available and readily available. And those tests, one doesn't actually need to, you don't need to go to the lab if you feel ashamed. You can actually mail your feces to the lab. You can courier it if you didn't know that part.
Oh, okay.
You can actually courier your feces there to the lab, and they test it, and then you are done. When the results comes back, you are done.
Okay. Thank you. Yeah, I think it's something that we can do with this changes in mobility now in the world. Tanya Mileva-Kombein wants to know, what is the treatment of and prognosis of serrated HAMN, I'm not sure what it is, discovered accidentally after right hemicolectomy for adenoma?
Oh, so
maybe you can explain what is this HAMN? Yeah.
Is the question in the chat box?
Yes, it is in the chat box. Yeah. Tanya Mileva-Kombein. Serrated capital HAMN.
Yeah, I can see that. So the prognosis is actually good. Remember,
maybe if you can explain what is this HAMN first. I don't know.
Hello.
Now, I say maybe if you can just maybe enlighten us about what this HAMN is.
So you have the polyps, and then you have a serrated sessile polyp. So that is it's a morphological feature of. Remember when you have adenomatous polyp and then you have serrated polyp, sessile polyp. So those sessile polyp are actually difficult to remove, and they are actually high risks as well. So that's why when those serrated polyps are high risks, are polyp, and then the serrated polyps are sessile polyp, which is not easy to remove. Okay. But in this case, they did right hemicolectomy and they found it on the specimen. But these serrated polyps, they have a low propensity to metastasize.
Okay.
So they have low propensity to metastasize. So the prognosis is actually quite good.
Okay.
Because serrated polyps are not, they hold a high risk, but they are not carcinoma. They are not carcinoma, so to speak.
Okay.
So but the prognosis is quite good if it was found incidentally. What would have happened is this: if it was found on colonoscopy, we would have tried to remove it without hemicolectomy and then follow the patient up 3 to 5 years. So the prognosis is quite good. The direct question.
And if you find it after right hemicolectomy, you also do the same.
If you find after right hemicolectomy, remember, by the time you do a right hemicolectomy, I would assume that you've interrogated the whole colon, which will advise you on doing the right hemicolectomy.
Okay.
Sometimes patient comes with an issue in the right colon. You are not able to interrogate the whole colon, but you advise that within 6 months of right hemicolectomy, you go interrogate the rest of the colon, and then you stratify that remaining left colon, and you follow it as in increased risk or average risk, depending on what you find. But usually, in most cases, when you go ahead to say, I'm going to do right hemicolectomy, is because you have already cleared that there's nothing in the left that will also want you to do a complete colectomy.
Okay.
So then you fall back into the average risk.
Okay, that's fine. Yeah. And the patient, 17-year-old male with no familial component, with newly diagnosed Crohn's, doesn't mean that one should screen routinely for Crohn's disease.
Yeah, remember now the recommendations is that you need to be screening 8 years, from 8 years after the onset or after the onset of symptoms. Mm-hmm. So once you're diagnosed from 8 years onwards, it doesn't matter which age, it just depends on how long you've had it. Then you start screening. So if this patient was diagnosed at 17, and then when you get to 25, they need to start screening for colorectal malignancy, because inflammatory bowel disease gives you the higher risk of developing colon, because you can imagine that you are having an inflamed colon that you're managing with steroids that also has their own disadvantages and everything. So that prones you to having a colorectal malignancy. So it's a high risk. So 25.
Okay. Now, Dr. Crombin, Minerva Crombin came back and said the HAMN is a high-grade appendiceal mucinous neoplasm. That's what when it is spoke about accidental finding after hemicolectomy. Okay, there's a question here from Dr. Kayens. How sensitive is colonoscopy in picking up the cancer at both flexures, that is hepatic and splenic flexures of the colon? How common is it?
You see, the sensitivity of a cancer, the sensitivity of a colonoscopy we have, it's about 93. It's not, I've never read anything that tells you specifically about the splenic flexure and hepatic flexure, because colonoscopy in a good hands, you need to know how to maneuver it to make those turns. Those areas indeed are not so easy to maneuver, but you need to be trained to know how to maneuver. But I've never read anything specific that says for splenic flexure is this much and the pickup is this much. It's just that the sensitivity is goes up to 93%, and which is a good pickup for the colorectal malignancy on colonoscopy. But remember also, colonoscopy in good hands, it gives you a high yield of pickup. So I've never seen anything that specifically states on a hepatic flexure and splenic flexure pickup. It's just the pickup of the whole colonoscopy.
Okay. We'll come back to colonoscopy, but I think just comparing PR exam as compared to colonoscopy, what is the role of PR examination as compared to colonoscopy, especially to those who cannot have access to colonoscopy?
Yeah, you see, unless if you are so much blessed that your finger is that long, you can compare colonoscopy. And
so it's quite limited. PR is quite limited, yeah, because it will just prosper the rectum.
PR doesn't even check the whole rectum.
Yeah.
So the highest roof of the rectum is 15 centimeters from the anal veg and the longest finger could possibly be 9 or 8 centimeter. And if you now include the bum in it of the patient, you are now only having 5 centimeter inside. No,
Yeah.
you can't. It's not comparable.
Yeah, no, definitely. Yeah. And is large scale screening possible in government hospitals?
You see, there is a question that we usually have, that the screening is labor intensive, and the screening, you need a workforce, and you also need resources, but it costs government more to treat one patient than to screen many patients. So the money you are going to invest from a patient coming in, waking them up, diagnosing them, waking them up from metastasis, taking them to oncology, and the resources that the patient will be using will be exhausting the system much more than if you actually enroll patient on the screening. Unfortunately, due to the limitation of resources, people are not willing to scope patients without an indication. And in this case, an indication means that that patient has fell off the screening. It's actually a patient that presents with something that negates you to put a colonoscopy. So in government hospitals, it would be easier if they're flexible sigmoidoscopy. So to do flexible sigmoidoscopy, you don't need to prepare the patients. And if you do flexible sigmoidoscopy and a fecal occult test, blood test annually, it gives you the same yield as the colonoscopy. So you don't necessarily have to be sitting there doing colonoscopy, which will be taking you 30 minutes or 20 minutes or an hour, depending on who you are and your experience in colonoscopy. But doing a flexible sigmoidoscopy can also be done by normal medical officers with experience. They can be taught how to do a flexible sigmoidoscopy, and then the fecal occult blood test would give you the same yield as somebody who's doing a colonoscopy in another institution. So that can still work. I believe it can still work. There's to just be a clear intention.
Yeah, sure. Yeah, but I think, yeah, because we've not had any large scale mobilization of surgeons to say it's like they do for cataract surgery and say that today we're going to have an outreach program. We're going to have so many patients done a colonoscopy. But I think you've just indicated the reasons why it is not as easy as we would love to do it. Yeah. Okay, I think we've exhausted most of the questions that you have on the chat box. There's someone who spoke about women, not clear what it was meant to be, but perhaps maybe just how to approach it for women, and because they are in terms of prevalence, it's quite low, but suppose they follow the same pattern of screening.
Yeah, but you must remember, I wouldn't want to segregate. So the screening of 45, I want us to look at it as for both males and females. Mm-hmm. The fact that it's more in males doesn't necessarily mean that females has to follow their own screening, and I'll show you why. If you have a female who's diabetic and a female who is not active, who's consuming a lot of alcohol and possibly obese, you should be screening that woman much more faster than a male if really the age is the only cause that a male has. So you see, so screening for women is the same as for males, but it's just that in males it's what we see than in females. But there are other factors that speeds up this process of female getting into this having colorectal cancer than males. So therefore, females have to follow the same screening ages for whether they have an average risk, high risk, or increased risk.
Okay.
The screening is the same.
Yeah. Maybe just a question from my side. When you've got people or family and people, someone has been diagnosed with colorectal cancer, and the prognosis, once it's diagnosed, the lifespan is quite limited.
Yeah. Yeah, you see, that is why this slide is very important. I'm going to highlight this point. And then you must remember that what we're trying to do with screening is that we stop patients before they have cancer, because once they have cancer, they tend to present at advanced stage. So you can see that once they're at an advanced stage, we know that they have a proper prognosis. But also the colorectal cancer is well known for recurrence. So once we take it and say, I got it early, 3 years later, there's a recurrence somewhere, or now you see that actually by the time you give them an operation, there was a cancer that you couldn't pick up in the liver. Now, a year later, the liver is full of cancer, and then the lifespan becomes quite low. So once it's diagnosed, the lifespan is actually quite low indeed. So therefore, that is why the prognosis is terrible. At 14% in 5 years is quite terrible. That means that if there's 10 people, only one is going to be alive after 5 years. So that means whatever work that you have done, it doesn't matter who you are. It's just that the presentation is late, because people are not going to save this themselves like they do with their cars. If I may say, you service your car before it gives you issues, you go park it there, they service it, but we don't do the same thing with ourselves, unfortunately.
Perhaps one of last question. When do you become suspicious? Once a patient, symptoms to look out for patients who you might have missed, who never got screened, and you are coming so that at least if maybe perchance if they can fit into that 14% survival rate, what are the telltale signs to look for?
Okay.
For patients
so
that once sees it.
Talking about symptomatic patients.
Yes, yeah.
So for me, if you see a patient who has a drop in HB, a simplest drop in HB without any history of them having an accident and bleeding or anything, so they're also losing weight unintentionally. So let's just do an HB. I wouldn't advise somebody to give somebody a patient supplements to pick up the HB without realizing the cause, because most of these patients, they have a right colon cancer. And the bad thing about right colon cancer, meaning ascending colon, hepatic fracture, and a cecum, is that the affluent is fluidy. So whatever that comes from the small bowel is still fluidy. So if somebody, the blood is mixed with the affluent, and only when the water is absorbed in a transverse and descending to form a stool, they're actually losing blood, but they're not realizing that they're losing blood because the stool is almost like normal. So those patients will drop an HB and you will transfuse them. The next thing, they will present with a mass on the right iliac fossa, and that's when you realize that the patient has cancer. So the worrisome sign is a drop in HB. Worrisome sign is then when somebody is losing weight unintentionally as well. Worrisome sign is somebody who comes and says, doc, I've been tired. They complain about fatigue with no reason. Those patients you must actually worry about, because that means as they go, they're losing strength, and it could be that because the HB is dropping. So those are patients that I would worry about. Mm-hmm. And those are the signs that when somebody comes in, you don't just send them to be transfused or give them supplements for them to correct the HB. Is that you send them for investigation, and when we get there, we won't transfuse them up until we know what type of anemia do they present with. If it's iron deficiency anemia showing that they are bleeding, we now have to go and find where the bleeding is. And I can tell you, most of them, we find them from the physicians. The physicians are giving us patients with low HB because they were sent to them because of a low HB, but then they are bleeding from a cancer somewhere.
Yeah. So the message is that any patient with low HB, don't give supplements until you've investigated for that.
That's correct.
Yeah. Okay, last question. Hope this is last question. And I think something like a pastor that you are. Yeah. And when I ask this question, I'm going to ask it because I'm unable to send, sometimes I use my phone to chat some people quickly when I want something. So Dr. Kenosh is in the audience. I'm going to ask him, I'm preparing him to give the last closing remarks as we ask this last question. Sure about that, Dr. Kenosh. Should we be, from Dr. Thabiso Moledi, should we be considering vitamin D, I don't know what, UA and homocysteine testing in assisting towards treatment, I suppose, for colorectal cancer?
What UA is.
Dr. Thabiso Moledi, if you can assist us What is UA? If you're able to unmute yourself, Kamo, if you can help Dr. Moledi to unmute himself. Doc, are you able to unmute yourself? Okay, but let's go to vitamin D in homocysteine testing.
You see, there are things that were postulated to be protective, meaning they would delay the proliferation from adenoma to carcinoma and uric acid.
I think it's uric acid. Uric acid.
Yeah. So then, what I have read is that the aspirin was postulated. I think it was also COX-1 inhibitor were postulated to be safe, because they have a aspirin which is the acetyl salicylic acid, not uric acid. So I haven't read anything about uric acid, and then the use of vitamin D, because then so what I've read about is the acetyl salicylic acid that half an aspirin a day would then slow down. It seems to be protective when they look at patients that have been taking aspirin once a day. But homocysteine and everything, I haven't read much about that. I've quite looked at many things, and I've been it has been my interest for long, but I haven't seen that. Sorry. I've only seen that the aspirin that seems to be protective, looking at patients that have been taking aspirin over a long time compared to ones that haven't been taking it. So they postulated that is one of the protective measures.
Okay. No, thank you very much. Just last word, Dr. Kenoji. If you're able to unmute yourself.
Yeah, thank you very much, Dr. Bila. And I should thank Dr. Kekana, who is one of our resident full-time surgeons within Clinics Health Group. I think for a very informative, well-presented talk on a very common and very worrying topic these days, colorectal cancer, becoming more and more common. I think probably most of us in the webinar today know someone close, if not a relative, someone very close, who has had the tragedy of having colorectal cancer. So this talk was timely, Dr. Kekana, very well presented, I must say, and we thank you very much for the talk. But this is a type of specialists we have within clinics, and we invite others from other places to also raise their hands and present on whatever topic that would be informative to colleagues on this platform. But thank you very much also to the board of Clinics Health Group, the managing director and board of health of clinics, for allowing us within clinics to have running these webinars ever since COVID times, since 2020. And I think they have outlasted many others who started during COVID. And I think
oh, you muted yourself, Doc.
To improve patient care. So these webinars, I think, costly as they may be, obviously they attract resources, will continue for as long as the professionals continue to log in. I noticed, Dr. Bila, that we had almost 400 people logged in tonight, and who gained from Dr. Kekana's talk. I should thank you, Dr. Bila, for the webinar master for a number of years. You have been. You're doing quite a fantastic job. I should thank the technical team behind Kamo and your colleagues in marketing and communication.
Anza joined us now.
Yes, and Anza Samadi as well, which is you're doing a fantastic job by keeping these webinars going. And for as long as people continue to register and partake and take part in the webinars, I think we in clinics will continue. Thank you very much, Dr. Bila. Over to you to close.
Thank you, Dr. Kenosha. Thanks for being with us this evening. And Dr. Kekana, we thank you very much for yeah, for this talk. And colleagues, thank you very much. Meet you again next week as we continue with one of our own clinics health group specialists will be giving us a talk. And thank you, Doc. And have a good evening.
Thank you so much. Thank you to everyone for being patient with the technology.
No, we got it right this evening.
Thank you.
Thank you.
Thank you. Good night.